Today we're going to be taking a look at post-renal acute kidney injury as part of the renal series. To start this topic, we can define an acute kidney injury as a sudden decline in kidney function, and this is reflected by an increase in serum creatinine or a decrease in the urine output. The reason why we use serum creatinine as a marker for renal function is because it's a muscle breakdown product, and importantly, it's freely filtered into the kidneys and is not reabsorbed back into the blood. To be more specific about the definition for an AKI, we can turn towards the KDIGO classification, and this basically helps to identify AKIs according to different criteria. The first criteria can be met if a patient's serum creatinine increases by more than 26.5 micromoles per liter within a 48-hour time frame. Alternatively, if the patient has a baseline creatinine and the current serum creatinine is around 1.5 times or more greater than this baseline, this would also confirm an AKI, as long as this happened within a 1-week time frame. Additionally, we can also look at urine output. So if the urine output falls below 0.5 milliliters per kilogram per hour for more than 6 hours, this would also meet the criteria for an AKI. And there can be different stages of acute kidney injury, depending on the level of rise in serum creatinine, and this ranges from stage 1 to stage 3. The other main aspect to understand about this is the basic anatomy of the urinary tract system. We have our kidneys, which produce urine, and then we have these hollow tubes known as ureters which carry it. The bladder then stores the urine, and when it's ready for excretion, it can be released via the urethra. We can split acute kidney injuries into different types depending on which part of this process is affected. So for example, there could be a pre-renal AKI, which involves insufficient perfusion of blood to the kidneys. Alternatively, we could have intrarenal AKIs, where there's direct structural damage to the kidneys themselves. And finally, there could be post-renal AKIs, where there's obstruction of urinary tract output. And we're mainly going to be focusing on the latter, so the post-renal AKI, in this video. Now, when thinking about post-renal obstructions, we can divide these into extrinsic causes and intrinsic causes. Starting with extrinsic obstruction, this could be due to an external tumor which pushes on a part of the urinary system and thereby prevents the flow of urine. There could also be causes such as benign prostatic hyperplasia, which is where the prostate gland becomes quite enlarged in males and pushes on the urethra, preventing proper urinary flow. Turning towards intrinsic obstruction, this can be due to tumors within the urinary system itself, for example, tumors of the ureters, the bladder, the urethra, or the prostate. There could also be strictures where basically parts of the ureters become more narrower compared to usual. As well as this, there could be renal or ureteric stones which block one part of the urinary system, and these stones are often formed of calcium oxalate. Some patients may also develop a neurogenic bladder, where the bladder doesn't contract properly, and this leads to accumulation of urine over time. Regardless of the cause, in all of these cases there's some level of outflow obstruction, and this leads to buildup of back pressure all the way back up to the kidneys. Over time, this can lead to a process known as hydronephrosis, which is where fluid swells around the kidneys and prevents proper functioning. There can be different stages of hydronephrosis depending on the level of severity of obstruction. To see the impact of this, we can trace our way back up to the nephrons, or the structural units of the kidneys. And what happens in a post-renal AKI is that these nephrons become flooded with fluid, which prevents them from working properly. To make things easier to explain, we're going to represent the nephrons like this. We have an afferent arteriole which brings blood in, a glomerulus in the middle which helps to filter products, and an efferent arteriole which takes blood out. Again, in a post-renal obstruction, there's some level of blockage which results in fluid buildup all the way back up to the glomerulus. If we compare this to a normal nephron, in this instance we have a good pressure of blood which helps to push small molecules out of the blood and into the nephron tubules. On the other hand, in a post-renal obstruction, although we have a good blood pressure coming in, this is matched by the pressure of the fluid from the blockage, and as a consequence we get a reduced pressure gradient. This means that the small molecules are no longer forced out of the blood as easily as before, and this results in insufficient filtration and subsequent buildup of the particles over time. Based on this, we can say that post-renal acute kidney injuries will lead to a reduction in the GFR, or the glomerular filtration rate. And this leads to azotemia, which is a buildup of waste products, as well as oliguria, so a decrease in the urine output. As well as this, the blockage of urine can often result in patients experiencing abdominal pain, and in some instances hematuria, so blood in the urine, especially in cases of renal stones or in specific types of urinary system cancers. Another useful value to look at is the blood urea nitrogen to creatinine ratio, and to understand this we can return to our diagram again. What happens in the early stages of a post-renal AKI is that the high fluid pressure actually forces molecules of urea and sodium to move from the filtrate back into the blood. Importantly, creatinine is not reabsorbed back in this process, because that's one of the characteristic features of creatinine. It's freely filtered and not reabsorbed. As a consequence of this, in the initial phases of a post-renal AKI, we would get a high BUN to creatinine ratio, because more urea is being reabsorbed compared to normal. However, as the AKI progresses, what can happen is that the fluid buildup actually damages the cells of the tubules, and this impairs the ability of reabsorption of both urea and sodium back into the blood. Again, we don't get any creatinine reabsorption, because that's what normally happens. Therefore, in the later stages of a post-renal AKI, we would actually get a reduction in the BUN to creatinine ratio, so this is usually less than 15:1, and this is due to the impaired reabsorption caused by the dead cells. In terms of the investigations for post-renal AKI, this can be assisted with routine blood tests, such as a renal profile, looking at the electrolyte levels, and as we mentioned, the BUN to creatinine ratio. We can also look at more specific blood tests, such as prostate-specific antigen, or different types of tumor markers, which might be elevated depending on the type of cancer present. Urinalysis can also be a useful tool because we can look at the urine sodium levels, as well as the presence of blood, which might indicate stones or specific type of urinary system cancers. Finally, we can take a look at different imaging modalities, such as an ultrasound of the urinary tract or a CT-KUB, which can help to identify the pathology present. In particular, CT-KUBs are useful at diagnosing renal stones, as you can see from this image here where the white opacifications represent stones on both sides of the urinary tract system. When thinking about the management of post-renal AKI, this is largely dependent on the type of pathology which is present. In the case of renal stones or ureteric stones, if the stone is less than 5 mm and the patient stable, we may adopt an analgesia and watchful waiting approach. If, however, the stone is greater than 5 mm or the patient unstable, we can turn towards surgical options, such as shockwave lithotripsy. In this process, we can use high-frequency sound waves to break stones into smaller units, which makes them easier to pass into the bladder and therefore into the urine. Alternatively, another approach is to use ureteroscopy, which is a process where a wire is inserted into the ureter to remove the stone directly. For more complex cases, patients may be offered percutaneous nephrolithotomy, which is where a tube is inserted through the skin to remove the stone, which is usually lodged within the renal pelvis. Turning towards benign prostatic hyperplasia, this is a condition which involves enlargement of the prostate gland in males, and we can adopt a medical management approach initially to try and treat this. This can involve using medications such as alpha blockers, including doxazosin and tamsulosin. To explain how these work, the smooth muscle around the prostate gland in BPH patients is often in quite a contracted phase. These alpha blockers help to reduce the level of contraction and thereby allow the normal flow of urine through the urethra. Another type of medication which might be used is a 5-alpha reductase inhibitor, such as finasteride, and this works by basically helping to reduce the rate of prostate enlargement, and in some cases it can actually lead to shrinkage of the prostate. Again, this helps with the urinary symptoms. If medical options fail and the patient is still symptomatic, we can turn towards surgical options instead, which might include transurethral resection of the prostate. Finally, in cases of urinary tract system tumors, the management will largely depend on the type of tumor present and the staging of the cancer. But possible options could include chemotherapy, radiotherapy, or surgery. To finish off, we have a summary slide here which outlines the key points from this presentation. I hope you found this video helpful, and I'll see you in the next one.